In this video, we will cover ptosis in detail. Ptosis refers to a drooping of the upper eyelid below its normal position. It can be present at birth or develop later in life, and correct classification is essential for diagnosis and management. A careful history helps differentiate congenital from acquired ptosis. Variability and fatigability suggest neuromuscular causes such as myasthenia gravis. Old photographs may be used if history is unclear. Pseudoptosis is a false appearance of ptosis without true eyelid pathology. Pseudoptosis must always be excluded before labeling a patient as true ptosis, as management differs completely. Loss of globe support as seen in anophthalmos of phthisis bulbi can cause pseudoptosis. Contralateral lid retraction creates an illusion of ptosis in the opposite eye. Ipsilateral hypotropia, brotosis, and dermatochalasis are common mimickers. Objective measurements are essential for grading severity and planning surgery. The important measurements in ptosis are margin reflex distance, palpebral fissure height, levator function, upper lid crease height, and pre-tarsal show. Margin reflex distance is the most important clinical measurement. It is the distance between upper lid margin and corneal light reflex. The normal value is about 4 to 5 mm. Reduction in margin reflex distance directly reflects the severity of ptosis. Based on this, the ptosis can be graded into mild, moderate, and severe ptosis, the droop being up to 2 mm, 3 mm, and 4 mm or more respectively. The palpebral fissure height helps in comparing unilateral ptosis and assessing symmetry. It is the distance between upper and lower lid margins in primary gaze. The upper lid margin rests about 2 mm below the upper limbus, and the lower lid margin rests about 1 mm above the lower limbus. The normal value in males is about 7 to 10 mm and in females about 8 to 12 mm. Unilateral ptosis is assessed by comparison with the contralateral eye. Levator function is the single most important determinant of surgical choice. It is a measurement of lid excursion from down gaze to up gaze. Firmly press a thumb against the brow to eliminate frontalis action, and patient is asked to look down. Patient then looks up as far as possible. The upper lid excursion is measured using a ruler. Grading of levator function is as follows. Normal is 15 mm or more. Good 12 to 14 mm. Fair 5 to 11 mm. And poor 4 mm or less. The clinical significance lies in surgical planning. Poor levator function suggests congenital myogenic ptosis. Upper lid crease height is the distance between the upper lid margin and the lid crease in down gaze. The normal value in females is about 10 mm and in males about 8 mm. The clinical significance of upper lid crease height are: absent lid crease in congenital ptosis indicates poor levator function. High lid crease suggests aponeurotic ptosis, usually involutional. It is used as a guide for skin incision in some surgical procedures. Pre-tarsal show is the distance between the upper lid margin and the skin fold with the eyes in primary position. Increased pretarsal show is seen in aponeurotic ptosis. Asymmetry is cosmetically important. Some associated examinations done in ptosis are pupillary examination, increased innervation to levator muscle, fatigability test, ocular motility examination, jaw winking phenomenon, Bell's phenomenon, and tear film assessment. Let's see the importance of each one of them. Pupillary examination is done to exclude Horner syndrome and to rule out pupil involving third nerve palsy. Increased innervation may flow to the levator muscle of a unilateral ptosis, particularly in upgaze. Associated increased innervation to the contralateral normal levator will result in lid retraction. The examiner should therefore manually elevate the ptotic lid and look for drooping of the opposite lid. If this occurs, the patient should be warned that surgical correction may induce a lower position in the opposite lid. Fatigability is tested by asking the patient to look up without blinking for 30 to 60 seconds. Progressive drooping of one or both lids or an inability to maintain up gaze is suggestive of myasthenia gravis. Other associated signs in myasthenia are Cogan's lid twitch, which is overshoot of the upper lid on saccade from down gaze to primary position, and a hope on side gaze. Ocular motility examination is essential in congenital ptosis. A superior rectus weakness may coexist. Correction of hypotropia may improve ptosis. Third nerve paresis must be excluded. Jaw winking can be identified by asking the patient to chew and move the jaws from side to side. Elevation of ptotic lid with jaw movement is seen. It is seen in Marcus Gunn jaw winking syndrome. Bell's phenomenon is tested by manually holding the lids open. Ask the patient to attempt forceful eye closure. The normal response is upward and outward rotation of globe. Poor Bell's phenomenon increases the risk of postoperative exposure keratopathy. Tear film assessment. Poor tear film volume or stability increases postoperative complications. It must be addressed before ptosis surgery. Classification of ptosis. The etiology of ptosis can be classified into neurogenic, myogenic, aponeurotic, and mechanical. Neurogenic ptosis is an innervational defect seen in third nerve palsy and Horner syndrome. Myogenic ptosis is caused by myopathy of the levator muscle or impairment of transmission of impulses at the neuromuscular junction, seen in myasthenia gravis, myotonic dystrophy, and progressive external ophthalmoplegia. Aponeurotic or involutional ptosis is caused by dehiscence, disinsertion, or stretching of levator aponeurosis. It is common in elderly. High upper lid crease and deep upper sulcus are characteristic findings. In severe cases, the upper lid crease may be absent. These patients have good levator function. Mechanical ptosis is caused by impaired mobility of the upper lid due to dermatochalasis, large lid tumors such as neurofibroma, scarring, or severe edema. Congenital ptosis is caused by dysgenesis of the levator muscle rather than nerve involvement. It is often sporadic and sometimes familial. The key features of congenital ptosis are absent or poor upper lid crease, poor levator function, lid higher in downgaze, and associated superior rectus weakness. Complications of congenital ptosis are amblyopia, chin elevation, and refractive errors. Amblyopia may result from visual axis occlusion or associated astigmatism, making early detection crucial. Treatment of congenital ptosis is usually attempted during preschool years once accurate measurements can be obtained. But it is done earlier in severe cases to prevent amblyopia. Levator resection is usually required. Marcus-Gunn-Jowinking syndrome or congenital synkinetic ptosis is due to aberrant innervation between the levator muscle and muscles of mastication. The lid elevates with jaw movement. The diagnosis is clinical and becomes obvious when the patient chews or opens the mouth. It is usually unilateral. In mild cases, observation is sufficient. Surgery is done if significant functional or cosmetic problems arise. For mild cases, unilateral levator advancement, and for moderate cases, unilateral levator disinsertion plus ipsilateral frontalis suspension are preferred. Bilateral levator disinsertion with bilateral brow suspension may be carried out to produce a symmetrical result. Third nerve misdirection syndromes. These patients develop abnormal synkinetic movements following nerve injury. Lid elevation or adduction, or inverse Duane syndrome, lid elevation on downgaze, pseudo-Von-Graffi sign are examples. Treatment is by levator disinsertion and brow suspension. Correct surgical planning requires accurate measurement and understanding of the underlying cause. Choice depends on levator function, severity of ptosis, laterality, and patient age. Levator resection or advancement. Levator surgery shortens or advances the muscle to elevate the eyelid. It is used when levator function is fair or good. It can be done through anterior or posterior approach. Predictable height correction is an advantage of this procedure. Conjunctiva Muller muscle resection relies on Muller muscle contribution and is suitable only in selected cases. It is used in mild ptosis with good levator function. It gives a maximum lift of 2 to 3 mm. Frontalis suspension allows eyelid elevation through brow movement. It is indicated in severe ptosis and is the procedure of choice in poor levator function. This procedure uses fascia lata or synthetic sling. Some exam relevant points are: in congenital ptosis, lid is higher in downgaze. Aponeurotic ptosis has good levator function. Margin reflex distance is the most important measurement in ptosis. Poor levator function needs frontalis suspension.